Okay, let's unpack this one. We're doing a deep dive today, really getting into a topic from the world of veterinary medicine. It's about a pretty common complication, actually, something that can crop up even during standard patient care. It's called phlebitis.
And our main source here, it's veterinary phlebitis management and prognosis.
Right, that's the one. And our goal really is to walk you through this. We want to pull out the key stuff, what is phlebitis? Why does it matter? What's it look like? And importantly, how do vet teams manage it? Or even better, how do we prevent it in our animal patients?
Yeah, get to the core insights for you. Cut through the noise.
Exactly.
Because it is interesting, like the source shows how something so routine, putting in an IV, can potentially cause real problems down the road.
Absolutely. It really can. So, okay, basics first. What exactly is phlebitis in our veterinary patients?
Well, put simply, phlebitis is just inflammation of a blood vessel wall. The source is specific. It says it's primarily an inflammatory process affecting the inner lining of the vessel. That's called the tunica intima. And you most often see it associated with peripheral IV catheters, the ones in the leg usually.
Okay, inflammation of that inner wall, the tunica intima. Got it.
Huh?
And I saw the term thrombophlebitis in there too. How's that different?
Right, so thrombophlebitis adds another layer. It means you got the inflammation plus the formation of a blood clot, usually a fibrin clot, and this can happen in those superficial veins near the skin or sometimes in deeper vessels.
Inflammation, sometimes with a clot.
Yeah.
Okay, so how does this actually, kick off? What's the cascade the source talks about?
It seems to start when that inner lining, the endothelium, gets irritated or the source uses the word sensitized. Basically, the vessel wall gets aggravated.
Right.
And that sets off this whole sequence. The vessel releases these vasoactive substances. They cause it to tighten up a bit, vasoconstriction, and also make the walls more permeable. Exactly, leaky. It also activates the clotting system, and it sends out signals, chemotaxis, telling inflammatory cells like leukocytes, get over here.
Wow, okay. So the vessel gets annoyed, gets leaky, starts clotting, and calls in the inflammatory troops. What does that actually look like then, the direct result?
Well, because it's leaky, plasma fluid leaks out into the tissue around it. That causes swelling, edema. And the clot itself can block blood flow. Sometimes you can actually feel it, like a thickened kind of hard cord under the skin where the vein is. And if it's bad, this damage and clotting can lead to irreversible scarring of the vessel, wall vascular sclerosis, they call it. Plus, those inflammatory cells, they release pyrogens, which can cause a fever and, systemic inflammation body-wide.
An infection.
Yeah, if bacteria get involved, you might see actual exudate, like pus draining from the IV site.
Okay, that paints a pretty clear picture of the process.
Yeah.
Who are we typically seeing this in, and what body systems feel the impact?
The source focuses on dogs and cats. It doesn't really single out any specific age, breed, or gender, though it does mention that maybe neonatal and geriatric patients, the very young or very old, might be more predisposed, maybe weaker immune function.
That makes sense. And systems-wise?
Well, obviously the skin right there is affected, local inflammation, maybe infection. The cardiovascular system is ground zero, right? Altered permeability, blocked blood flow. But then systemically, the immune system kicks in big time. And if inflammatory stuff or bacteria get circulating, you could see organ dysfunction. And the really scary part is the respiratory system. If you get deep venous thrombophlebitis, a piece of that clot can break off.
An embolism.
Exactly, a pulmonary embolism.
Yeah.
Travels to the lungs. Very serious.
Yeah, pulmonary embolism is definitely a major concern. Okay, so how often are we actually seeing this? The numbers in the source seemed kind of high.
They are surprisingly high, yeah. The incidence is quoted as somewhere between 20% and 80% of hospitalized patients getting peripheral IVs.
Wait, 20 to 80? That's a huge range.
It is a huge range, but even 20% means it's happening a lot. It's definitely not uncommon. Most are the superficial type, thankfully. But the source does say about 10 to 12% of those superficial cases might progress to the deeper, more worrying kind, deep venous thrombosis.
10 to 12% progressing.
Okay.
That's still significant. That frequency range alone is a big takeaway. All right, so we know what it is, the process. How do we spot it? What are the key signs we should be looking for?
The source gives a pretty clear checklist for local inflammation right at that IV site. You need to see at least 2 of these signs. Redness, which is erythema.
Right.
Pain, heat coming off the area, swelling, or the vessel itself feeling hard or like a cord.
2 of those 5.
Okay.
Anything else?
Yeah, you might see drainage or exudate, especially if there's infection, maybe an abscess forming, or even lymphedema, which is swelling from lymphatic issues. And systemically, a fever could indicate wider inflammation or an infection that's spread.
Got it. Local signs are key. Now, let's dig into the why. What are the main culprits causing this?
The source kind of groups them. First up is mechanical injury, just, physical trauma to the vein. Could be the catheter itself, its size, how stiff it is, how long it's in, or trauma during placement, maybe multiple pokes needed.
Yeah, difficult placement.
Exactly. Or even just infusing fluids at really high rates can be mechanically irritating.
Okay, so the physical aspects, what's next?
Chemical injury. This is irritation from what's flowing through the vein. Sometimes the catheter material itself, but often it's the drugs or fluids. Solutions that are really concentrated, high osmolality, or have extreme pH levels.
Less than 5 or more than 9, I think it said.
That's right. pH under 5 or over 9, those are really tough on the vessel lining. Parenteral nutrition, IV feeding can do it too.
Right.
And certain known irritant drugs, vesicants.
Ah, okay. So the stuff in the fluids. And then the obvious one, infection.
Absolutely. Bacterial colonization,
Yeah.
huge factor. Often tied to technique, maybe not perfectly sterile placement.
Aseptic technique failure.
Right. Or poor catheter care afterwards. And of course, patients who are already septic or immunocompromised are just more vulnerable. Bacteria can sneak in through breaks in the IV line, come from the skin, or even be circulating in the blood already.
Makes sense. And the last cause was about blood flow.
Yeah, obstructed blood flow. If the catheter is really big for the vein, or the vessel clamps down vasoconstriction, or if the patient's hypotensive, low blood pressure, so flow is sluggish, or simply if a thrombus, that clot, starts forming and physically blocks things up.
Oh, okay. Lots of potential triggers there. Does the source mention specific things about the patient that make them more susceptible? Risk factors.
Oh, yeah. Duration is a big one. How long the catheter is in, significantly higher risk if it's in place longer than 72 hours.
3 days.
Yeah, 3 days seems to be a key point. Although, interestingly, the source noted it increases with duration over 72 hours, but didn't show a huge jump specifically between 72 and 96 hours. Kind of a nuance there.
Huh. Still, that 72-hour mark is definitely something to keep in mind.
For sure. And the type of infused, as we said, caustic stuff, hyperosmolar, things that trigger the immune system, especially big, fast boluses.
Okay. And Virchow's triad was mentioned. That sounds pretty clinical.
It does, but it's a core concept for thrombosis, for clot formation. Applies in vet med, too. Triad means 3 things. 1, hypercoagulability, the blood clots too easily. 2, blood flow issues, slow flow, turbulent flow. 3, vessel wall damage.
Ah, and phlebitis is vessel wall damage.
Exactly. So phlebitis is often providing that third leg of the triad, making clots much more likely.
Got it. That connects the dots. Any specific patient conditions that ramp up the risk?
Yep. Things like obesity, being immobile, having poor veins generally.
Makes placement harder, too.
Right. Immune system problems, conditions making blood thick or clot prone, like thrombophilia or hemoconcentration.
Right.
Chronic heart or kidney disease, even pregnancy. And then the underlying disease itself matters. Cancer, existing infections, major trauma, respiratory or circulatory failure. They all add risk.
That's quite a list. Covers a lot of our typical patients. So, okay, we suspect phlebitis based on those local signs.
Yeah.
How do we confirm it? What's the diagnostic workup look like?
Well, first, you got to think about what else it could be, the differential diagnosis. Could it be, say, an allergic skin reaction? Or vasculitis for another reason, maybe just a skin infection nearby, or some other injury? Rule those out.
Okay, rule out the mimics. What about lab work?
Blood tests can help. A CBC might show signs of inflammation, like high white cells or maybe platelet changes if there's clotting. Biochemistry, urinalysis, those are important if you're worried about organ damage from an embolism like kidney or liver hits. And specific clotting tests, PT, PTT, D-dimer, maybe others can show if the coagulation system is out of whack.
Labs give the systemic picture. How do we actually look at the vessel itself? Imaging?
Angiography or phlebography, injecting dye and taking x-rays, that's supposedly the gold standard, but it's invasive.
Right.
CT or MRI might be used if you suspect deep tissue clots. But more commonly available, ultrasound is mentioned, B-mode, duplex, different types. Less invasive way to see if the vessel's open, if blood's flowing. Availability can be an issue, though.
What about simpler tools?
A basic Doppler ultrasound, it's pretty inexpensive, just uses sound waves to listen for blood flow, tells you if it's patent or blocked. And if you suspect infection,
Culture it.
definitely. Culture the catheter tip after you pull it. Culture any drainage. And if the patient seems systemically sick, maybe blood cultures too.
Good range of diagnostic tools there. And if we
Yeah.
could, like, biopsy the area, what would we see pathologically?
Grossly, just looking at it, the vessel would look narrowed, thickened. The tissue around it might be swollen, maybe discolored. You might actually see clots inside. Under the microscope, histopathology, you'd see what we talked about. Swollen endothelial cells lining the vessel, inflammatory cells infiltrating the wall, fibrin deposits, maybe a full-on thrombus.
Okay, so the microview confirms the process.
Yeah.
Right, we've diagnosed it. Let's switch gears to management. What's the absolute first, most critical step the source emphasizes?
Get the catheter out. As soon as you suspect or know it's phlebitis, remove the IV catheter from that site immediately.
Step 1. Remove the source of irritation. Makes sense. What comes next?
Well, if infection's suspected, start appropriate antibiotics. Often empirical at first, like covering common skin bacteria. Then maybe some topical therapy or wound care for the site itself. And crucially, monitor the patient closely, especially during any ongoing infusions elsewhere, for any reactions. The source also really highlights listening to the patient pain at the site or during injection is often the very first clue something's wrong, like phlebitis or extravasation.
Listen to the patient's signals. Good point. Are there things to do during infusions to minimize risk at other sites?
Yes, definitely. Big one is avoiding those really irritating solutions peripherally, the ones with extreme pH or osmolality. And if you're using a central line, a bigger, deeper catheter, you have to check for blood return, get that flashback before infusing to make sure you're actually in the vessel.
Good practice. What if you think one of those nasty vesicant drugs is leaked out? Extravasation.
Okay, first, stop the infusion immediately. But leave the cannula in for just a second. Try to pull back, aspirate any fluid you can that leaked out. And if there's a known antidote for that specific drug, you can try instilling it into the tissue through the cannula before you pull it out.
Ah, clever. What about local treatments? Things you put on the site?
Warm, moist compresses often help.
Hmm.
Hydrotherapy, though the source notes for some specific leaked substances, cold might be better. Photobiomodulation, low-level light therapy, LLLT is mentioned too. Applied over the area, it's thought to reduce inflammation, maybe activate stem cells for repair, improve blood flow.
Interesting. And preventing clots.
Keep the patient well hydrated, that's key for blood flow. Volume resuscitation if needed. And encourage movement physical therapy, maybe compression wraps on the limb to help circulation and prevent stasis.
Hydration and mobility, foundational stuff, but really important here.
Yeah.
Okay, thinking about nursing care. Any specific pearls or maybe slightly counterintuitive points from the source?
Aseptic technique for placement, obviously non-negotiable. Sterile dressing. Now here's an interesting one. With gauze dressings, the advice is actually not to check the site super frequently, maybe only every 48 hours to avoid messing with it. But transparent dressings, the see-through ones, are actually preferred because you can look at the site often without taking the dressing off.
Okay. More visualization, less manipulation. Makes sense. What about antibiotic ointment at the site? Lots of people do that.
Yeah, the source specifically says don't do it. Topical antimicrobial ointments are not recommended. They haven't been shown to reduce infection rates, and worse, they might actually encourage resistant bacteria.
Wow, okay, that's a big one. Skip the ointment. Any tips on where to place the catheter or which type to use?
Try to avoid lower legs, joints, places near nerves. Use smaller bore, longer catheters if you can. And polyurethane material is preferred over Teflon.
Okay. And checks. How often should we be looking at these things, and how often should they be changed?
If fluids are running continuously, check the site, patency, line integrity, swelling every 1 to 2 hours. Peripheral catheters, generally change them every 3 to 4 days. Or sooner, like within 24 hours, if it was placed in an emergency without perfect sterile technique. But for central lines, routine replacement is not recommended. Leave them if they're working well.
Good guidelines there. What about activity and diet? Do they play a role?
Yeah, moderate, regular activity helps reduce thrombosis risk. So physical therapy, range of motion, especially for patients not moving on their own, is important. Diet-wise, it's mostly about supporting their overall health, treating the underlying illness, and maybe glycemic control if sepsis is a concern.
Right, support the whole patient. How much should owners be told about this? Client education.
Super important. Discuss the risks of IVs, especially if the pet has known risk factors. And if they're going home with ongoing issues, maybe train the owner on some basic PT or care for the site.
Makes sense. Is surgery ever needed?
Sometimes. If the site gets badly infected or tissue is dying from extravasation, it might need surgical debridement cleaning it up, maybe delayed closure. In really severe cases, with that hard corded vessel, they might even do surgery to tie off or strip the vessel to stop clots from spreading deeper.
Okay, surgery for the tough cases. Let's talk drugs. What medications are typically used?
Well, antibiotics if infection's suspected, like we said. Maybe something broad like cephalexin initially, and then adjust based on culture results if you get them. NSAIDs, nonsteroidals like meloxicam can really help with pain and swelling, improve comfort.
What caveats, right?
Big caveats. Be careful with kidney, liver, GI problems, and watch out for interactions if the patient is also on steroids can impair healing.
Okay. What about the clotting risk? Heparin?
Yeah, anticoagulants are often used. Low molecular weight heparin can help prevent clots from forming or getting bigger, reducing embolism risk. Also, using heparin flushes tiny amounts of dilute heparin, like 100 units per ml, just to keep the catheter patent, might reduce phlebitis incidence and help the catheter last longer.
But potential interaction there, too.
Yes, definitely watch out if giving systemic NSAIDs, especially aspirin-like ones that hit platelets hard, along with heparin, increases bleeding risk, coagulopathy.
Good to know. Are there topical meds, things we can put right on the skin over the site?
Yes, several interesting options mentioned. Heparinoids, topical creams with heparin-like effects. They act as anticoagulants locally, help break down clots, improve blood flow, seem better for treating existing phlebitis than preventing it, maybe. Notagosazine cream from a type of ginseng apparently showed effectiveness for pain, redness, swelling, even that cord formation.
What else?
Nitroglycerin. Patches, creams, gels, not sprays, the source says. It causes local vasodilation, opens up the vessels, works fast within 10 minutes, lasts a few hours. Good for prevention and early treatment.
That's useful. Any other topicals?
Topical NSAIDs like piroxicam or diclofenac gel can help with signs and maybe speed things up. Alternatively, silver sulfatazine cream for irritation, infection prevention, or even medicated powders like Gold Bond just to keep things dry but not on broken skin.
Well, one last medication point, patients on vasopressors, drugs to raise blood pressure.
Right. Those patients are actually more prone to thrombophlebitis. So for them, using a topical vasodilator like the nitroglycerin is specifically recommended.
Okay, that covers a lot of ground on treatment.
Yeah.
So looking ahead, what's the follow-up, the prognosis? What do we watch for?
Monitor closely. Are the signs getting better or worse? Persistent redness, swelling, pain, heat. Adjust antibiotics based on cultures if needed. Really bad signs, like the vessel feels rock hard, the skin looks pale or even black, or there's an eschar, like a scab. That means tissue necrosis, tissue death.
Definitely bad signs. How do we stop it happening again in that same vein?
Pretty simple. Avoid using that vein again for IVs or blood draws until it's totally healed. And for prevention generally, especially in high-risk cases, the source mentions considering submicron IV filters. They go in the line, filter out tiny particles, toxins, inflammatory stuff from the fluid. Might help reduce incidence.
Interesting tech. And the potential bad outcomes, complications if it goes wrong?
Well, tissue necrosis, nerve damage leading to loss of function, lymphangitis, sepsis.
Bloodstream infection.
Yeah. And the big one we mentioned, extension into the deep veins with the risk of pulmonary embolism.
Right. So finally, what's the usual course, the prognosis overall?
Thankfully, most cases are mild. They resolve within, say, 1 to 3 days after you pull the catheter. Prognosis is usually good then. Though that specific vein might not work as well afterwards, its patency could be compromised long-term.
But if it's severe?
If you have severe local damage, it can take weeks, maybe 3-4 weeks to heal, and might leave permanent damage or loss of function. Prognosis is more guarded then. And prognosis is always guarded if it's associated with those major complications, pulmonary thromboembolism or sepsis.
So, yeah, quite a spectrum. Mild and quick to resolve, or potentially severe, long-lasting, even life-threatening.
Exactly, which really underscores why catching it early and managing it properly is so, so important.
Wow, yeah, that was incredibly thorough. It's crystal clear that phlebitis isn't just some minor inconvenience in vet med. It's common, it's complex, depends on the catheter, the fluids, the patient, and the key really seems to be good technique, vigilant monitoring, and acting fast, starting with just getting that catheter out.
It really does. It shows how these, seemingly small details, what catheter material, how often you check the wrap, can genuinely impact patient outcome and prevent some really nasty complications.
Absolutely. Which I guess brings us to a final thought for you listening. Given that really high incidence rate we talked about, that 20, maybe even up to 80%, and the potential for serious fallout like PE or sepsis, how might really understanding these specific risk factors we covered change the way we approach routine IV care, and maybe even how we talk to owners about it. From everything we just discussed, what really jumps out to you is the single most critical prevention tip, the one thing to really focus on in practice.